Good evening, everybody. Thank you for joining today's webinar. We will be starting momentarily. All right. Good evening, everybody. Thank you for joining today's webinar series. We're really excited to have everyone here. I see we have many members slowly joining. So just to let you guys all know, we will be recording this webinar. So if at any point you do need to jump off, you will be able to access the webinar on the OTIP June Health portal, in addition to the full presentation as well. So I just wanted to let everybody know that you can access the content at a later time. All right, so just before we get started, I just wanted to share a couple of housekeeping items. If you are a member that is looking to consume the content in French, we do have access to Wordly. The link was sent in your email. We also have a QR code here up on the screen. So it's quite easy to use. All you need to do is select French, click attend, and then the captions will appear in a new window. Also, just for ease of use, if you do prefer to use the audio translation, it tends to work best when you join Wordly on a second device, like either your phone, while keeping Zoom open. All right, so with that being said, I'm going to turn it over to Krista from OTIP to share a couple of words.
Great, thanks very much, Baz. Good evening, everyone. My name is Krista Gingrich, and I am a group benefits consultant here at OTIP. We're excited to be here with you to introduce the OTIP's Women's Health Webinar Series. This was created exclusively for OTIP members in partnership with June Health and MemberRx. This series was designed to empower and support women through every stage of their health journey. As someone who spent a number of years helping others navigate through their benefits and wellness options, I didn't quite imagine how personal this journey would become. I'd already entered perimenopause myself, and it was a phase that crept in quietly. First, it was a subtle shift in my energy, my sleep, and my mood. At times, it felt overwhelming. I was experiencing hot flashes, even panic attacks, and more so when my mental health felt fragile. But through educating myself and getting support from my naturopath and my family doctor, I found an understanding of what my body and my mind were trying to tell me and how to navigate to get to the new me. Because let's face it, this phase of life, it just changes you. All this helped to shape my commitment to women's health, not just in benefits, but in real conversations that we're here for tonight. Women's health has long been surrounded by stigma, and it's a time to start changing that stigma through connection, education, and self-advocacy. This initiative reflects our commitment to advancing women's health and fostering an environment where women feel supported, understood, and empowered to thrive. We thank you all for taking the time to join OTIP and June Health this evening and keep the conversation around women's health going. With that, I'm pleased to introduce Lori Castleman, founder and CEO of June Health. Lori is a seasoned healthcare executive with deep experience in employee benefits and health technology. At Sun Life, she led health solutions, scaling wellness programs, and earning the CEO Award of Excellence. She went on to serve as Chief Health Officer at League and later served as President and CRO at Wello. Most recently, until June, she led TELUS Health's Global Consumer Health Division. A frequent speaker at industry events, Lori is now bringing her expertise and passion to building June Health, where she and her team are transforming health experience for women. Their mission is to provide health care that is connected, convenient, and personalized, and to make sure women's voices and experiences are finally heard in the healthcare system. We are fortunate to have Lori with us today and share a word of welcome and set the stage for this important conversation. Please join me in welcoming Lori Castleman.
Thanks so much, Krista. Really appreciate the warm introduction. It is such a pleasure for us to be working with you, Krista, and with the incredible team at OTIP on this very important area of focus that is women's health. I wanted to share a fun fact. There are two industries in particular where the population skews predominantly female, and they are healthcare and education, which is why it's particularly inspiring to see leaders like OTIP really prioritizing the women's health focus in their strategic plans. At June Health, this is also our mission to build the tools, education, and clinical support to prioritize women's health journeys every day. We know that women are at the heart of families and communities, and in fact, Research does show that it's women who make 80% of healthcare decisions within households. Unfortunately, too often these women put their health last on a long list of priorities. And it's our goal to help change that dynamic by making education, support, and better care convenient and accessible. And on that note, it's my distinct pleasure to introduce you to our incredible medical director and one of my co-founders here at June Health, Dr. Rami Nitsch. Dr. Rami, as we affectionately call her, is a practicing OBGYN, has been a member of the surgical departments of both Kingston General and Sunnybrook Hospitals. And she is part of the teaching faculty in medicine at Queen's University as well. Rami brings deep expertise in the women's health space and really drives the focus on our clinical and care team at June Health. And so without further ado, it's my pleasure to turn it over to Rami to take it away.
Thanks, everybody. Thank you, everybody, for joining us in this last week of summer holidays for such an important topic. I've been a women's healthcare provider for well over 20 years, and I can't say how much it means to me for an organization such as OTIP to demonstrate such incredible leadership when it comes to creating a menopause inclusive environment. I'm going to take you to our agenda for the evening. Someone like Sarah over the last few years. Sarah is a 42-year-old elementary teacher. We're having a little bit of slide issues right now. We'll get back on track in just a second. Here we are. So Sarah is a 42-year-old elementary school teacher. She's a mom of 2 kids. She's incredibly busy, and she's currently grappling with irregular periods, mood swings, and fatigue. These symptoms were initially chalked up to just stress and juggling everyday family life. Sarah was starting to feel isolated and unsure where to turn. Sarah's experience reflects that of 1 in 3 women who start perimenopause before the age of 45, incredibly common. Her journey is going to help us navigate the myths, facts, and reality of menopause with honesty and compassion. We're going to follow Sarah throughout this journey. As you can see, Sarah looks very happy on the slide. This is a picture taken after Sarah's received all the help that she required. I'm going to go over some of the top 10 menopause myths I hear. I hear these from my patients coming in to see me, from searches they've done on the internet, common conversations that people have. And so I think tonight we're going to set the record straight on some of these common myths. So number 1, only older women experience symptoms. Menopause happens abruptly. It's only about the hot flashes. Menopause doesn't affect mental health. All women experience menopause in exactly the same way. Weight gain is absolutely inevitable. Menopause is the end of your sex life. Natural remedies are always safe. Menopause hormone therapy is unsafe, and menopause hormone therapy is the only option out there. So let's talk about myth number 1. Only older women experience symptoms. The bottom line is perimenopause or menopause can start much sooner than you think. It wasn't until I started going through my own perimenopausal journey that all of those stories that women have been telling me over the years finally made sense. So the bottom line is that perimenopause is the transition phase before menopause. It can begin in the late 30s, sometimes the early 40s. This is related to hormonal fluctuations. The ovaries are starting to think about retirement, so there's changes in estrogen and progesterone. This starts to trigger all of those symptoms of perimenopause. These symptoms can last up to 10 years. The frustrating thing about some of these symptoms is that they actually can be quite nonspecific, and they are often mistaken for stress, aging, or even depression. Many women are actually unaware that they are in perimenopause. I have a lot of women come to see me and say, I simply just don't feel like myself, and I don't know what's going on here. Unfortunately, there's a lot of cultural silence and stigma that often hinders open discussion at home, in the workplace, and actually with a lot of healthcare professionals that aren't as familiar with treating the perimenopause and menopausal phase. And healthcare providers, they may often overlook hormonal causes as responsible for a lot of these symptoms that are causing the distress and impacting quality of life. The other thing that makes things challenging is there can be some significant barriers to access. In 2002, there was a large clinical trial uh, known as the WHI, and it created widespread fears about hormone replacement therapy. The problem with the trial is it only looked at older women. It only looked at one type of estrogen and progesterone. It overstated some of the adverse or serious consequences of being on menopause hormone therapy, and it overlooked any of the benefits. And as a result, there was an entire generation of women that were deprived menopause hormone therapy. Some of these persistent misunderstandings and fears are still existing today, unfortunately. There's also limited training amongst general practitioners on menopause management. In fact, less than 7% of general practitioners provide comprehensive menopause care in Canada. There are long wait times for specialists. It can sometimes take 2 to 3 years to get into a specialist such as myself if you have a non-urgent issue. There are also few menopause-specific clinics, although this is starting to change, and that's a really good thing. Canada is a big country, and we know that there are significant healthcare inequities by region and by culture. And I would say, even though menopause is having a moment, it's being talked about a lot more in the media, there is still a cultural stigma and silence around menopause that actually continues to prevent open conversations. Furthermore, women often don't know where to go to find reliable and effective care. So let's talk about myth number 2. A lot of people think that menopause happens suddenly, but in fact, menopause is a very gradual transition, often taking years, and can involve a number of different stages. Some of the menopause symptoms and life implications can be things like emotional symptoms. People might start feeling more anxious. There might be more significant mood swings. There can be irritability and low self-esteem. In women that already have a background of mental health issues, some of these emotional symptoms might actually be heightened, and it can be really distressing. There can actually be increased stress and coping issues. There can be increased difficulty managing workload, both at home and in the work environment. Work performance might suffer because of things like fatigue, brain fog, and poor sleep. And this might also reduce productivity. When we talk about brain fog, it's important to understand what that is. It can sometimes be described as issues with memory or clarity and focus. A lot of women also describe this as a time where their relationships with their partners, with their children, and with their parents might be a little bit more strained. This might lead to compounding mood changes, emotional withdrawal, or even misunderstandings. Sometimes women describe their social life as completely changing. While they might have gone out before and didn't have problems going to a work event or something at their child's school, some women actually describe avoiding social events simply because they feel tired or embarrassed, or maybe they're experiencing increased hot flushes. Over time, there can be a cumulative effect that generally impacts quality of life, and this can increase the risk of burnout. So what is menopause exactly? So we talked about perimenopause as that transition time where the ovaries aren't functioning regularly and estrogen and progesterone are in fluctuation. Well, true menopause is when the ovaries have gone into retirement, and it's defined as 12 consecutive months without a period. The average age for menopause is 51 years of age, and it's marked by decreased estrogen levels. Although it is a natural biological process, it has significant health implications. Let's talk about myth number 3. We all joke, or not joke, and talk quite seriously about hot flashes, but menopause involves many symptoms beyond hot flashes. So what are hot flushes? Let's talk about those first. Hot flushes are something called a vasomotor symptoms. So for women, they can be realized or experienced quite differently. So some women might typically get that feeling of feeling extremely hot. There can be excessive sweating. Sometimes people describe it more as their heart racing. And actually, a number of women actually experience a chill. Hot flushes can present during the day, and they can also present excessively during the night, which leads to the next symptom of sleep disturbance. In my clinical practice, I would say that most women find sleep disturbance the most disturbing symptom in menopause. So sleep disturbances can range from insomnia, not being able to fall asleep, or you can fall asleep, but you wake up several times in the night, or you fall asleep and you're up at 3 o'clock in the morning, and that's the end of your night. Menopause can also be a time where women experience weight gain and metabolic changes. And even if there aren't associated weight gain changes, women often feel distressed about how their body might have changed during this time. And we come back to mood because mood can be a significant distressor during this time. Women might experience increased anxiety, depression, and irritability. Other common symptoms, we talked about brain fog and memory lapses. Some women say they can do their job really well during the day, but when they come home, everything falls apart and they have difficulty concentrating on the tasks at hand. Some women also express that brain fog and memory lapses deeply affect them in their work environment. It can be quite common for shift workers to experience heightened sense of brain fog and memory lapses. Often not talked about, but a very significant symptom. And I would say one of the other common symptoms that women come to talk to me about is vaginal dryness and painful intercourse. Women might also experience joint aches and stiffness. Women might get distressed by their hair thinning out, falling out, and there can be increased skin changes, hair growth on the face. This might be a time where acne increases. Women also describe urinary frequency and increase in infections. It's not, these symptoms impact women significantly throughout the day, but they also have other impacts that compound each other. So those vasomotor symptoms, those hot flushes and sleep disturbances, they disrupt work. People say it might be difficult to get through a meeting, teach a class, deliver a brief. Vasomotor symptoms also significantly impact sleep, which contributes to brain fog and memory lapses. Poor sleep reduces concentration, productivity, and just feeling good about yourself. Weight changes can really be distressing to women. This is related to metabolic slowdown. And as I said, the weight can shift sometimes from different parts of your body. So while estrogen might have been responsible for some of your weight being distributed to your thighs, this now moves to the central belly, and women find this quite distressing. As it relates to mood, people experience increased emotional volatility, and this leads to significant mental health impacts. This can once again make it very difficult to do your job and enjoy good quality of life. So menopause doesn't affect mental health. Mental health is probably one of the greatest effects during the perimenopause and menopausal journey. Hormonal changes can directly influence mood, memory, and mental health well-being. Unfortunately, this leads to significant issues in the workplace. The problem is many workplaces have inadequate workplace policies to support changes in mental health and to support women through the perimenopause and menopausal journey. That's why embarking on this journey with OTIP is so important for the work environment. I can't tell you how many letters I write for people because they feel that they simply can't do their job. They can't sleep, so they can't be their best possible selves at work. Women also express that they have a fear of a stigma associated with this, that you should just suck it up or deal with it. It's part of life. That's still said to women quite often. And so there can be a silent suffering. These things lead to increased absenteeism. It might lead to problems with you're at work, but you're not putting your best self forward. And this is often a time where women are striving for leadership positions or changes in career. And perimenopause and menopause without the right health attention can actually cause career setbacks. The most frustrating part that women express is that their mental health symptoms are often misdiagnosed or undertreated. So they have to suffer for years before they get the help that they require. There are some rather real health challenges of menopause that we should not underestimate. Menopause significantly impacts bone health. This leads to a higher risk of osteoporosis. When women have osteoporosis, they're at higher risk of experiencing fractures, and fractures like hip fractures can lead to serious hospitalizations, surgeries, and actually even have a morbidity and mortality associated with them. This is also a time where cardiovascular health is compromised. Women are at increased risk of heart disease, and there are lots of good studies to show that women presenting to the emergency room with cardiovascular symptoms are often undiagnosed and unrecognized. Going back to mental health, this is a time of increased anxiety, depression, and some women often express to me that they feel they have cognitive decline, that they just are not the person they were a few years ago, and they can't do their job, and they're not functioning well at home. One thing that makes menopause and perimenopause challenging to treat is there's a misconception out there that all women experience menopause in exactly the same way. The bottom line is there is not a one-size-fits-all. Every woman's menopause journey is unique in timing, symptoms, and impact. That's why it's really important for someone like me as a healthcare practitioner to really listen to what women are telling me. A common question I get are, should I get my hormones tested? So there are many commercial tests out there. I did a survey of the internet today, and some of the hormone testing that is provided either by a send in your saliva or send in your urine sample, women are actually being charged anywhere from $200 to $600. The bottom line is most of these commercial tests are completely unnecessary. One thing that's really important about hormones is that levels fluctuate daily, and so we cannot rely on a single measurement in time. As a menopause practitioner, my diagnosis is mainly clinical. It's based on the symptoms that women describe to me. I often don't need to do a hormone test to diagnose perimenopause and menopause symptoms, and more importantly, to provide appropriate treatment. The bottom line is care focuses on how women feel, not on lab numbers. There can be certain situations where your physician, nurse practitioner might order some laboratory values, but I would strongly encourage people not to invest in expensive commercial hormone testing. The other thing that's really important, because menopause is not a one-size-fits-all, is a need for a holistic, multidisciplinary approach to menopause care. As you can see in the things I've described on previous slides, menopause impacts physical, emotional, cognitive, and social health. So comprehensive care should integrate medical practitioners such as myself to guide women in making a choice for menopause hormone therapy or non-hormonal medications. Women might also need mental health support, Physical activity is important. So is sleep optimization and weight management. A team-based approach adapts to evolving needs and quality of life. The other thing that women find quite distressing is weight gain or change in body. Weight gain is not inevitable. It's not a done deal. However, it can be challenging to manage. That's why it's important that we incorporate lifestyle, nutrition, and activity to influence weight changes during perimenopause and menopause. The truth about menopause and your body. Let's talk about weight for a minute. Why do women gain weight in menopause, or why are there changes to body habitus? The first is that with declining estrogen levels, I mentioned previously that our fat distribution in our body changes. So from our thighs to our central belly. The second reason is when your sleep's affected, this deeply affects your cortisol level. Cortisol makes people crave sugar and further impacts weight. Menopause also causes a loss in lean muscle mass. That is where most of our calories are burnt. And finally, you can't continue to eat the same because sometimes our bodies during perimenopause and menopause are actually craving things like more protein to stabilize weight and kind of eliminate those changes to body. So lifestyle, nutrition, and regular activity can help manage all of those shifts in metabolism. Strength training and resistance training is key during menopause, and that's really to support that muscle mass and metabolism. Mindful eating and portion awareness can reduce unwanted weight changes. That always sounds a lot easier than it is to put into action, especially in our busy lives where we're trying to do our job. And in perimenopause and menopause right now, we're often described as that sandwich generation, taking care of our children and taking care of our parents. So mindful eating sometimes goes out the window, but can have impacts. So it can be really important to work with the right allied health professionals, such as a dietitian or a nutrition expert or a fitness expert, to really get those evidence-based strategies that can make a real difference. Women can feel really powerless about taking control of weight and body changes, but with the right person, it's important to remind people that we're not powerless and we can take that control back in our life. So probably the third biggest thing that I hear as a gynecologist is menopause has ended my sexuality. The bottom line is this is not the end of intimacy. Many women with the right guidance and support can continue to enjoy fulfilling sex lives during and after menopause. There can be a number of reasons that women experience sexual health concerns during menopause. So number one is low libido. So hormonal changes can reduce sexual desire. Women do produce testosterone, and when the ovaries go into retirement, that testosterone level fluctuates. There can also be some real physical discomfort. Women experience vaginal dryness and thinning of the vaginal tissues. This can cause pain during intercourse, otherwise known as dyspareunia. This can have some real emotional consequences. It can lead to frustration, feelings of anxiety and depression. There might be relationship impacts. This is often why I encourage my patients to bring their partners to appointments. And this can lead to a cycle of distress. So physical symptoms that are the really real pain that women are experiencing might lead to emotional withdrawal, which can impact relationships as well. Support is often needed, and often women don't know where to go. It might be a family physician or a gynecologist such as myself or a nurse practitioner. There are people that have specialties in sexual health medicine. So finding the right support can be challenging, but once you've landed in the place where the support is there, a lot one. So I talked about the WHI trial of 2002, which basically led to widespread fears that menopause hormone therapy is unsafe. Many, many moons ago, when I was a resident, we put most women on menopause hormone therapy if that's what they chose to be on. And then that study came out and everybody came off. And as I said, it really led to a generation of women being deprived of menopause hormone therapy. So there, you might still hear the old term hormone replacement therapy, but we're really moving to a more inclusive term of what hormones are supposed to do, which is menopause hormone therapy. And that's to suggest that by giving women estrogen, progesterone, and sometimes testosterone, they are offering therapeutic benefit for those perimenopause and menopause symptoms. So the new term, or the more accepted term, is menopause hormone therapy. The benefits are absolute symptom relief for most women, although I would still say it's not a one size fits all. And when you work with a healthcare practitioner to decide which is the best menopause hormone therapy to go on, your practitioner might have to play around with different delivery systems and doses. The other incredible thing about menopause hormone therapy is it might also offer bone, heart, and cognitive protection as well. It's important to remember that most of the fears around menopause hormone therapy are outdated. We're often asked about the risk of breast cancer. So to put it into perspective, the rate of breast cancer in Canada is about 23 per 1,000 women in Canada. On menopause hormone therapy, that risk increases to about 27 per 1,000 women. The important thing is, though, there is no difference in the mortality rates of women on hormone replacement therapy and women not on menopause hormone therapy. So once again, it's about a really careful and directed conversation with a healthcare practitioner. Menopause hormone therapy is safe for most women when started before age 60 or within 10 years of menopause. This is also not an absolute, and there can be reasons to start it when women are older. The duration of menopause hormone therapy should be very individualized and reassessed by a healthcare practitioner. Menopause hormone therapy can reduce those vasomotor symptoms on hot flushes and night sweats. Menopause hormone therapy can improve sleep for most women. It can support weight management, and it can also help stabilize mood, reduce anxiety, and clear brain fog. Women start to feel much more like themselves after going on menopause hormone therapy. As I said, there are some real long-term benefits. Menopause hormone therapy protects bones. It supports heart health. And the newer thing around menopause hormone therapy is if it is started at the right time, it might actually lower Alzheimer's risk in women. And most significantly for many women, menopause hormone therapy can maintain and help improve urogenital health. So it can actually improve vaginal lubrication, decrease pain during intercourse, and it can reduce urinary tract infections in women in perimenopause and menopause. I can't emphasize enough that it's not a one-size-fits-all, and that starting menopause hormone therapy really requires a personalized conversation with a healthcare practitioner. The healthcare practitioner will review personal and family history to make sure there's no particular risks. They will discuss different ways to take menopause hormone therapy. They will also provide regular reassessments, and it's really about collaborative decision-making. I often will offer many options to the people that come to see me, and we make a decision together about what will best mitigate their symptoms and meet their needs and meet their comfort level. So the other myth we hear is that menopause hormone therapy is the only option. That is not true. And every year, It's exciting to be a healthcare practitioner in these times. There are other options to treat some of these very real symptoms of perimenopause and menopause. Effective treatments can include things like lifestyle changes, other medications, and changing things like diet, exercise, and different approaches to sleep. It's really important, as I said, to have a holistic approach to menopause care. So it's really about combining the medical, the lifestyle, as well as improving these. Many women that come to see me, I often refer them to a mental health support worker, a psychologist, or a psychiatrist to really help working on some of those workplace strategies to help balance symptom control and starting to feel more like yourself in your work environment. It's really important to advocate for inclusive policies in the work environment. That's why hosting webinars such as this are such a huge leap forward in creating a menopause inclusive environment. It's also important for women to build their own personal menopause toolkit. It is not a one size fits all. Sometimes people need more sleep support, more relationship support, more medication support. It really depends on the individual. That flew by. I feel like we could keep on talking forever. So we'll have more times for questions, which is great. So I just want to thank everybody for joining us tonight. I'm sorry my slides were being a little bit stubborn with me, but I just want to emphasize on a few things that you can do over the next week. You can start to track your symptoms to better understand pattern and triggers. You might not have realized that some of the symptoms you're experiencing are perimenopausal or menopausal related. It's really important to schedule a check-in with your healthcare provider to discuss any concerns. I know wait lists are incredibly long and that can be challenging. Try small lifestyle tweaks. Exercise a little bit more, slightly adjust your nutrition, and prioritize sleep. I know that as I'm reading all of these things, I find them very difficult to do for myself, but they're incredibly important. And most importantly, explore evidence-based strategies for managing things like hot flushes, moods, and sleep disturbances. There's a lot of misinformation out there. There's a lot of marketing, and it's really important to get very evidence-based strategies to provide you with the best tools to manage your symptoms. Start open conversations with your partners, friends, and colleagues about your experiences. The bottom line is that many of us at June and OTIP have been going through the perimenopause and menopause journey for years, and so we understand.
Thank you so much, Rami. I am going to jump in here. And at this point, we're going to actually open up the Q&A portion of the webinar. So first of all, Rami, thank you. I mean, I think that was an incredible amount of information, really, really helpful information. And I really love the point that you made about the fact that everyone's journey is different. And I think, covering the many myths, tips, and tools for us to be thinking about, gives us all something to sort of work on and keep focused on as we continue our journeys, right, through perimenopause and menopause, which, again, I would say perhaps a not so fun fact is the fact that this can be an 8 to 10-year journey for many women. I think that was, really important information for me. I thought this was going to be sort of a stage that I hit and it would be kind of one and done. And unfortunately, it really doesn't work that way. There's many different symptoms and experiences that women have. So, I think the more education and support that we can get, the better. And so on that note, let's open up Q&A. I think there's been a number of really fantastic questions that we received in advance of today's session. And I can see our kind of Q&A here on the side of the webinar actually lighting up too. So lots of excellent questions. So We will do our best to answer as many as we possibly can. I do want to note as well, what you see on the screen here is a QR code for a feedback survey on today's session. We will also include the link in the chat for the survey. And I really want to encourage everyone who participated today to just take 2 minutes and quickly fill out that survey and give us your feedback. You know, the team at OTIP is also looking for your input on future sessions, which is one key question in that survey. So please do take a moment before we wrap, sort of over the next half hour, to fill out the survey. Okay, so without further ado, Rami, I'm going to just start with a couple of key questions that I've seen a number of times here. So the first is, do you recommend any particular vitamins or supplements be taken during perimenopause and menopause?
Yeah, it's a great question, and I don't think it's actually asked enough in my environment. But calcium really supports strong bones and can reduce that osteoporosis risk as estrogen declines. Vitamin D is key to take with calcium because it helps with absorption and might actually improve mood and immune function. There's some great evidence that magnesium can help with sleep, bone density, and there's more information coming out on magnesium and pain, as well as potentially high blood pressure. And then omega-3 fatty acids are really good for supporting reduced inflammation and supporting heart health.
Excellent. Okay, follow-up question. So we had an individual ask if there's any natural supplements that help specifically with libido.
Okay, so while I am not an expert on the more natural substances that are out there, people can work with a naturopathic doctor. But my sort of review of the literature shows a couple things. So there's something called maca root, which there's some what we call small clinical trials that actually suggest that it might improve sexual desire and reduce sexual dysfunction. And there's also some early research that suggests that saffron might improve sexual arousal as well as lubrication.
Okay, excellent. Next question, is it safer for me to take bioidentical hormones?
Okay, so we're asked that a lot.
Mm-hmm.
So let's talk about what bioidentical hormones are. So bioidentical hormones are made in a lab, and the purpose of a bioidentical hormone is to mimic what your body produces. So some forms of bioidentical hormones are approved by what we call Health Canada. They're called micronized progesterone. A lot of women would be on that. And then there's also estrogel or estradiol. Those would be kind of more well-known bioidentical hormones. The important thing to know about bioidentical hormones is they are not all regulated and they're not all Health Canada approved. And what that means is you might not know the exact quantity of the medication dosing, and you might not know what additives are in the bioidentical hormones. So while many can be good choices approved by Health Canada, I think it's really important to work with a physician or a nurse practitioner or a naturopathic doctor to make sure you're getting the right bioidentical hormones.
Okay, excellent. Next question, and this is a specific example. So we had a question where an individual indicated that they started bleeding within a few months of starting menopause hormone treatment. And the question is that normal?
Yeah, so within the first 3 to 6 months, certainly a little bit of spotting or bleeding can be quite normal. I always encourage people when they leave their appointment with me not to make their own adjustments to their menopause hormone therapy, but rather to come back and talk to me about that. Sometimes we have to calibrate the dosing a little bit differently. Once in a while, bleeding can indicate something more serious. And so we certainly would always want somebody to touch base with a healthcare practitioner if this were to occur. But within the first 3 to 6 months of starting menopause hormone therapy can be quite common.
Okay. Next question, does testosterone help for libido?
Okay, so that's the big question. We're asked that a lot. And The answer is maybe. So one of the more commonly prescribed testosterones in Canada is something called androgel that's placed on often on the shoulder or buttock or thigh. And the purpose of androgel is to improve libido. It might also improve energy level and just an overall sense of well-being. The bottom line with androgel, though, is it's still considered off-label for this type of use. And that's because the medical evidence is a little bit unclear. So if I start women on androgel, I would say half see some real benefit and half see no benefit at all. The other important thing about androgel is you really want to work with a healthcare practitioner before starting it. Don't order it off online. There can be some really important blood tests to do before starting androgel or any type of testosterone, as well as some follow-up blood tests to make sure that you're staying within the safe range of treatment.
Okay, very helpful. Next question, is excessive sweating a symptom of perimenopause?
Definitely. So it goes with those hot flushes. That's that decrease in estrogen level. Some women experience extreme sweating, drenching their clothes, having to change their clothes. Women tell me they bring multiple outfits to work. They have to leave to go and change their clothes. The other thing women will often talk about is a change in body odor during perimenopause and menopause. And this is related to decrease in estrogen, increased sweating, increased bacteria. So women go through multiple deodorants before they feel that they find one that's really addressing that body odor issue, needing to shower. So it's one of those, I don't know what's happening to me, but it's all related to perimenopause and menopause.
Okay, great. I'm going to throw in my own question here. Just
About
for
you?
fun. I feel like it's the question that everyone wants to ask. It may or may not be about me. Is excessive irritation natural during perimenopause and menopause,
Like
particularly
feeling irritated?
feeling irritated?
Yeah. 100%.
Is there any clinical reason why that would be the case that we can use to explain that to our families and those around us as we're going through perimenopause and menopause?
Well, I think, similarly to how some women experience PMS, some women are very sensitive to those like hormonal fluctuations. So because your ovaries are not ovulating at a regular interval anymore, that irritation can creep in all over the place. So some women actually experience true rage. I've had a few of my patients actually bring in their partners and make me explain it to them. And people will describe that they actually like they cannot control those symptoms of irritability and rage. They feel really out of control. So, once again, if this is a new symptom for you and it's creeping up on you, there is help.
Yes. Okay, thank you. Okay, next question. The question is around health history with breast cancer. And so if an individual has a relative or any type of history in their family with breast cancers, can they go on MHT?
Yeah, it's a really important question. And I feel like it's often a group of women that are really underserviced by addressing the quality of life issues associated with perimenopause and menopause. So a couple things. It depends. So it depends on the type of family history and the type of breast cancers. As I said in the presentation, if we take all women, there's only a few more women per 1,000 women that will experience a diagnosis of breast cancer and menopause hormone therapy. So if we take that back, most women, even if they have a relative with breast cancer, can safely go on menopause hormone therapy after a careful discussion with a healthcare practitioner. The good news is, though, there are other options. There are recently some new medications on the market to address hot flushes that do not deliver increased estrogen and progesterone. So this actually might be great for women who themselves have breast cancer as well. But a family history of breast cancer does not mean that a woman is not a candidate for menopause hormone therapy.
Okay, very helpful. Okay, next question. How do I deal with menopause belly fat?
Yeah, that one's tough. So as I said in the presentation, Women might not experience an absolute weight change, but there can be a change in the way that they feel their body looks. This can be distressing to some women. And that reason is that estrogen, that evil culprit, is shifting the body fat to different parts of the body. So what's important? Strength training and resistance training is key. When you're in menopause and perimenopause, your lean muscle mass comes down. So you can't burn calories the same way. So getting that muscle mass up is really helpful. Really adding more protein to your diet. So working with a registered dietitian or a nutrition expert is really important. Sleep, sleep, sleep. I can't talk about sleep enough. I think it is the #1 distressing symptom that women have. When you don't sleep, you have increased cortisol, leads to sugar cravings, and once again, compounds that weight issue. So, it goes back to a conversation with a nurse practitioner or physician. Maybe you're a good candidate for menopause hormone therapy, working with allied health to address diet, fitness, and exercise, and mental health support if it's incredibly distressing.
I am going to ask a couple more questions that we received in advance, and then I'm actually going to add some of the questions that we're seeing coming in through the chat. We have 98 questions so far coming in through the chat.
And Lori, just to that point, we knew that we weren't going to it's so great to have all those questions, and we might not get to them all tonight, but we will do a follow-up newsletter on question highlights.
Yes, and I will also add, there's a lot of questions about today's session. So the session is being recorded and the recording will be made available on the portal. So it's the same portal where you saw the registration link, the OTIP June Health portal. And so you can always go back to that particular portal to grab the recording, and that's where we'll put some of the information from the newsletter and additional sort of educational content as well. Okay, next question. What is non-hormonal medication?
Like an option other than a hormonal medication?
Correct.
Yeah, so we have a better understanding, for example, of why hot flashes might occur, and it might actually be related to certain aspects of brain function. So there are some more
Oh, Rami is frozen here for 1 second. So maybe we'll give this a sec to see
there
if...
can be some more natural products that are
Sorry, Rami, you froze for a second.
Oh,
So I'm
am I
going
back
to
up?
restart the answer to that question, if you don't mind.
Oh yeah, no problem. So there can be a range of non-hormonal options. So there are some new medications that directly target certain receptors in the brain that might mitigate hot flashes. There are some more natural remedies like evening primrose oil or black cohosh that might help with menopause vasomotor symptoms. And then, we talk about sleep issues with perimenopause and menopause. Menopause hormone therapy does not fix sleep issues for all women. And so you might have to have a very careful conversation about other sleep medications, techniques, even cognitive behavioral therapy that really might start to help address some of those real sleep concerns.
Okay, next question is, how do we know that menopause starts after 12 months of no period? What is the basis for that? So maybe you can talk about sort of the clinical definition of menopause and the sort of journey prior to as well.
Yeah, so the first thing that happens in the perimenopausal phase is that your ovaries start behaving a little bit more, I would say, unpredictably. So while most women will have a regular menstrual cycle before they hit perimenopause, one of the first things that happens is those cycles become irregular. So women will often experience irregular bleeding and then many of the symptoms we've talked about today. While we say it's the 12 months, is at that point, most women have officially gone into menopause. And on history, it's 12 months with no period. We can also do a blood test called an FSH, which will show us that women are in the menopausal range. But while you're getting sporadic periods, it's very unlikely that you're officially in menopause. The other thing is, I think women often don't get the care they need from healthcare practitioners and physicians, because they are also caught up with the fact that women need their treatment once they are officially in menopause. But it's that perimenopausal journey that is really distressing, has all of the same symptoms, and is often a time where initiating treatment is key.
I am going to add a little personal story here because I really sort of respect and was inspired by the fact that Krista did so at the top of the session as well. And I think it touches on the point that you just made, Rami. And I think it's probably very common, right? So
Yeah.
my whole journey into perimenopause, it just started with a series of symptoms that I didn't really know what was happening. It was those vasomotor symptoms where I couldn't really sleep and was having some challenges with, I would say, like early hot flashes. And when I spoke to my family doctor, what he was indicating to me during that period was that I needed to have missed 12 consecutive periods
Right.
qualified for any type of, hormone therapy. And I know we've had this conversation, but
Yeah.
I wonder if you can speak to that a little bit more for others as well, because I think your perspective on this was honestly just like incredibly, like both enlightening and also just helpful and life-changing, right? Because it set me on a care plan that made a whole lot of sense for me after 7 years of trying to get access to good care. And it's one of the reasons that we started June Health. So I wonder if you can just talk about that sort of misnomer of 12 months until you're qualified.
Yeah, for sure. And I think, Lori, just really comes down to like a misconception. As I pointed out early in the slide presentation, less than 7% of healthcare practitioners feel that they're qualified to address perimenopause and menopause. As someone that went through medical school, there's maybe like a tiny little bit of menopause, maybe less than an hour. So unless you're in, a training program or a profession where you're going to get a little bit more focus, you're probably going to stick to that. You need to be in menopause before you take these symptoms. But, that can't be further from the truth. And I can't tell you how many times I hear, I have been begging someone to put me on menopause hormone therapy. I know what these symptoms are, and I need them to be treated. And people literally feel like they're begging for the medication from one healthcare practitioner to the next, because their story is not being heard properly. And I think there's more medical evidence to suggest that perimenopausal window might actually be the key time for starting menopause hormone therapy. Not for everybody, and not if you don't have symptoms, but if you do, you might be getting that added benefit of decreasing your Alzheimer's risk. So your story is a very common story. I hear it all the time. And I think it comes down to women maybe saying, I don't know what's happening to me. And then finally they get into the healthcare system, and there's a real paucity in truly understanding what comprehensive perimenopause and menopausal care is.
Mhm. Thank you for that. Okay, a few more questions here. So, another question just around skin issues. And is it normal to see dry skin or get pimples during the perimenopause stage?
Yeah, all skin changes in women that have a predisposition or even have not had them before are more prevalent. So that includes things like acne, and people will often describe it around their mouth, a little bit of a different distribution. Dry skin, 100%, that's that decreased estrogen. And then if women who have clinical symptoms or histories of things like eczema, those things actually tend to get worse and flare in perimenopause and menopause. I have a lot of women come speak to me that they can't swim in the summer anymore, that they have terrible eczema, that the water aggravates it, the sun aggravates it. This wasn't a problem. Maybe they remembered distantly in childhood that they had eczema. The truth is that there can be some really simple solutions to buying the right types of cream and protective agents for your skin that can really make a big difference. As well as going on menopause hormone therapy, if that's right for the individual, can also help with skin changes. With skin changes also go brittle nails. People say their nails are breaking all the time and their hair is falling out. And this is very distressing for people.
Mhm. Absolutely. Okay, next question. are migraines a symptom of perimenopause? I've actually heard this a lot within my family and friend community as well. Lots of women experiencing headaches or migraines for the first time. So normal, is this common in this stage?
Yes, it can be very common. So a couple things about migraines. So migraines can be hormonally related. That's why many women get what we call a menstrual migraine or very cyclical type of migraines. And some women in perimenopause and menopause describe their migraines as debilitating, requiring often appointments with specialists. Women are often also told during perimenopause and menopause, if they had a history of migraines, that they cannot go on menopause hormone therapy. This is not true. With a very careful history and an understanding of migraine patterns, menopause hormone therapy can actually help treat some migraines. It doesn't work for everybody. I personally suffer from quite debilitating migraines and have recently had seen a neurologist because mine have increased as well. And it can be incredibly helpful. So just to remember, it's never that one size fits all, can be more common and requires the right type of treatment.
Okay. The next question is around estrogen patches versus pills. So can you talk a little bit about, the question is specifically, is a patch better than a pill?
Yeah, I would never say that one thing is better than the other. I would say a few things. So sometimes it comes just down to personal choice. Some people don't like to take a pill. They would rather have a patch or a gel. There can also sometimes be some very specific reasons when a healthcare practitioner might pick a gel or a patch. So for example, in someone's history, if they are at increased risk of developing a blood clot in their leg or their lung, we want to avoid oral estrogens. We really want to give that medication by a patch or a gel, and that will really mitigate that risk of developing a blood clot in the leg or lung. So once again, I wouldn't say one is better than the other. Comes down to personal choice and individual health risk.
Okay. There's a few questions here about blood work and, questions around like my doctor will or will not do blood work, and wanting to understand. There's a question here. My doctor won't do blood work, understanding that blood work only captures a point in time. So how do we know if we need MHT? And then also, how do we know if it's working?
Great question. So really I talked briefly about commercial blood tests that are available for cost. The bottom line is those are very similar tests that a physician such as myself can order. Once again, I would say that there are 9 times out of 10, we don't need to do blood work. We need to listen to somebody's story and make a clinical diagnosis. If you're having perimenopausal or menopausal symptoms, or for example, you've gone that 12-month window, that might be another indicator, then we can initiate treatment without blood work. There can be some very specific times when we might do blood work, but it's usually based on trying to understand something else, like is there also a risk of thyroid disease? Has somebody gone into what we call premature menopause? So somebody under 40, that might be a time where we do blood work. The bottom line is there is no blood test that is going to tell me whether menopause hormone therapy is working. Symptoms are the best guide. If you feel better, it's working. If some of your symptoms are better, but not others, we might need to make an adjustment. But I don't need to do that based on a blood test.
Okay. Next question. I'm going to ask a few that are more sort of women who are, I would say, like later in midlife. So this individual is asking, I'm 68 and I have menopause symptoms. My family physician told me it was too late to start hormones. Is this true?
Yeah, so we talked briefly around a slide that the ideal window is before 60 or within 10 years of menopause. That's because that is the greatest time where you'll get the greatest relief of your symptoms. It also probably offers the most health benefit as far as brain, heart, and bone health. Having said that, I have many women come to see me that are later in their menopause journey. After a careful conversation about their health risks, I do start them on menopause hormone therapy. There might be slight increased risks starting menopause hormone therapy at a later age, but the absolute numbers are quite small. But once again, it's really about that careful conversation. And whenever I start someone on menopause hormone therapy, I usually say, I have three types of people, some that come off very quickly, some that follow the typical 3 to 5 year window, and then I have my lifers. I have women in their 80s, they will not come off their menopause hormone therapy. They love
Okay, so, oh, you froze there for a quick second again, Rami. You were describing that last category. So the women who will never come off their hormone
Yeah, I
therapy.
call them my lifers. They're clinging to their menopause hormone therapy for life. And, it's just about having a careful conversation with a healthcare practitioner.
Okay, I think that's a perfect segue to the next question, which is there a rough timeline on what's considered too long to be on MHT?
Yeah, so our guidelines in the healthcare world and in discussions with our patients are usually a window of about 3 to 5 years. But having said that, those are guidelines. So, that's the time that most women will get the greatest benefit. After the 3 to 5 year window, I usually recommend if women want to stay on their menopause hormone therapy, I do once again a health survey, make sure they're getting all those good check marks, and then I meet with them on an annual basis, maybe even semi-annual if there are more things to discuss. But I think it really comes down to that individualized journey. So sometimes people will take a little break from their menopause hormone therapy and think, nope, I need to go right back on it. I felt much better on it. And I think that's okay if you have a careful conversation with the healthcare provider.
Okay, I've got a few symptom questions here. So, question is tinnitus a symptom of menopause?
Yeah, so it can't, I think everything's a symptom of menopause, but
Okay,
people
there's a list.
experience ringing in the ears, vertigo, dizziness, those can all be things that people do experience. So, but while we might blame a lot of things on perimenopause and menopause, a dangerous thing can also be to blame too many things on that. So if you have an unusual or new symptom, I would always recommend getting it checked out.
Okay. The next one, and I'm going to skip a couple. There was a couple around itchy ears, tinnitus, a number of things that I think you just touched on. This one I think is worth maybe just spending a quick moment on. So this is an individual, and I've seen a few asking about anxiety, depression, panic attacks, sort of mood disorders for the first time as they get into midlife. And so wondering if you can talk a little bit about the impact of hormonal changes on mental health.
Yeah, so I think it's really important that just because you don't have a history of mental health issues, perimenopause and menopause might be a time that you experience it. Secondly, those hormonal fluctuations definitely can have an impact. Firstly, directly, changes in hormone can have an impact with cognitive function and feeling of well-being. We also talked a lot about sleep deprivation, and then things like sexual health. If the people aren't feeling good about those things, they might also trigger new feelings of anxiety and depression. But it might also have nothing to do with perimenopause and menopause. So if those are new symptoms for you, it's really important to once again have a good discussion with a healthcare practitioner. Sometimes some of these symptoms are mitigated by medication, like menopause hormone therapy. Sometimes people do have to go on medications for anxiety and depression. Sometimes people don't need medications at all. They need to talk to a mental health expert or have counseling or support. So it's really important to take a holistic approach to mental health and really do a deep dive for each individual about what might be causing those distressing symptoms.
There's a few questions in sort of different formats here around birth control and individuals being told that if they are on birth control, they shouldn't be having symptoms of menopause and or don't need hormone therapy.
Yeah, so that's not true. Just that's a really common thing that I get when I meet my patients. So a couple things we've pointed out many times, it's not a one size fits all. So because you were on a birth control pill that worked for many years, all of a sudden it might not be working. And there are many reasons for that. Birth control pills have different doses at different times, so people might need a more equal dose. But if those symptoms are creeping in and they're real, then you need to have a discussion with someone. I often switch people from the birth control pill to menopause hormone therapy. Sometimes I even just start the birth control pill to control some of those symptoms. So it does really depend on the individual, but if someone has those symptoms, then they're absolutely real and things need to be adjusted.
Okay, I love this question. So some women say that their symptoms just gradually end or go away. Is that the truth? What causes menopause symptoms to end naturally?
Yeah, so the bottom line is we don't really know. And just like some women have absolutely no issues with perimenopause and menopause, pretty symptom free, for some women, their symptoms do just end. Um, Sometimes I'll see people, I'll start them on a medication, and within a year or so, they've stopped it and they feel fine. I don't think we totally understand what makes the perimenopause and menopausal journey different for different women, but absolutely your symptoms can stop. And so I think that's why we are always told to reevaluate menopause hormone therapy somewhere between the 3 and 5 year mark to see if women still require it.
Okay. Question around if I have an IUD, should I still experience symptoms? Or I wonder if this is similar to the birth control point, right? So if someone has an IUD, can they be experiencing symptoms of perimenopause and menopause?
Definitely. So the IUD only has one type of hormone, the progesterone hormone. It's really the decline in estrogen that contributes to most of the perimenopausal and menopausal symptoms. So while the IUD is great for menstrual related issues, it's not really going to help those menopausal symptoms.
Okay. Next question is, how can I treat low cortisol other than more sleep?
Yeah, so cortisol also can be one of those gimmicky commercial types of things. So I always tell people to be aware of overpaying for promises of cortisol. The truth is, unless you have an adrenal disorder, it can be difficult to do targeted treatment for cortisol. True adrenal issues are quite rare. And so, yes, the key is getting more sleep, sleep, exercise, and eating well.
Okay. Are vaginal creams with estrogen safe to use? And do you have any recommendations on which creams are the best?
Very safe to use. I just use the standard Premarin vaginal cream. The important thing is if you're using vaginal medications to treat issues of dryness or pain during intercourse or reduce urinary tract infections, it can come in a cream and a ring or a pill. The cream is the highest dose. So that means there's a little bit more absorption into the body. For most people, that doesn't matter. The pill tends to be the lower dose. And then for anybody with sort of mobility issues or difficulty doing those insertions themselves, the ring can be placed in by a healthcare provider and only needs to be replaced 4 times a year.
Okay. Is it common to have heavy periods for almost 5 years as a part of perimenopause?
So while it can be common, if this is a new symptom for somebody, I would strongly recommend seeing a family doctor, a nurse practitioner, or a gynecologist such as myself. In your 40s, there can be quite significant menstrual changes. It's actually an interesting phenomenon. The ovaries will actually occasionally release double estrogen. And so it can trigger some of those things like heavy menstrual bleeding in women with fibroids. It can actually make things worse. I would say, while it can be normal, that is something that I would seek help for to at least evaluate it and make sure that A, you're getting treatment, B, your iron levels are good, and C, there's nothing concerning going on.
Okay. So maybe a little bit of a clarifying question. So this individual was asking, saying that you had indicated that estrogel is not regulated. Can you please explain more about this and any risks associated with using estrogel?
No, estrogel is a regulated, or estradiol is a regulated bioidentical.
Mhm.
Estrogel is great. I prescribe it all the time. It's absolutely safe, and you can just put a couple of pumps on your arm daily or on your buttock or your thigh. The important thing is about estrogel is you want to stay away from breast tissue, but estrogel is very safe.
Okay, perfect. I wanted to make sure we had a moment to clarify that one. There's a few questions here about the connection between hormone therapy and Alzheimer's. In a few of these questions, it's sort of asking about, can hormone therapy help reduce risk for Alzheimer's, and why would that be?
Yeah, so it seems to be an emerging science that estrogen really does impact cognitive function. And so as estrogen levels decline, there can be obviously some impact on brain health, cognitive function, et cetera. The key thing about Alzheimer's risk reduction, it seems there's something called the switch. So starting that menopause hormone therapy at the right time, which is in that perimenopausal, menopausal window, starting menopause hormone therapy later on does not seem to offer the same benefit as far as Alzheimer's protection. Once again, we wouldn't put everybody on menopause hormone therapy to prevent Alzheimer's, but if you do have significant symptoms and you start menopause hormone therapy at the right time, this is an added health benefit.
Okay, so there's a few questions here about the connection between endometriosis and hormone therapy. So, a few individuals indicating they have had a history with endometriosis and are concerned about hormone therapy. And is there any risks because of this health history?
That's an excellent question. I see a lot of patients in my practice with endometriosis. And definitely women with endometriosis can go on menopause hormone therapy. The key is, though, always to be on both the estrogen and the progesterone. Often women with endometriosis have had a hysterectomy. And to complicate things, in women that have typically had a hysterectomy, they don't require the progesterone hormone. Except when you have a history of endometriosis, I always give both. And that's to stop the estrogen from causing that endometriosis to start to resurface. So really important to have a careful conversation with somebody that understands endometriosis. The last thing somebody with endometriosis wants is a flare in menopause when they're finally getting a break. But you can often take the right balance of menopause hormone therapy to treat your symptoms as well as mitigate any of those endometriosis flares.
Okay. Next question, does cannabis have negative impacts on perimenopause symptoms, or can it be helpful?
I think there probably are mixed opinions out there. Some people do feel that cannabis does help with sleep, pain in the joints. I have some women on cannabis that actually think it heightens their anxiety and hot flushes and does impact their sleep. So this is a time that they come off of it. Cannabis can come in a number of different forms. So sometimes people will use oils, soaps, or butter, for pain or sleep. I think it's very individualized. And so I would say, while it might help with symptoms for some women, for other women, it might aggravate their symptoms as well.
Okay. Is there any connection to seizures starting during this time and hormonal changes?
I think potentially there could be, but if someone was experiencing new onset seizures at this time, it would be really important, obviously, to have that evaluated. But just like some people experience change in seizures with different phases of their menstrual cycle, the same type of hormonal impacts, might have some impact on seizure function, but really important to make sure someone's getting the right kind of care. And once again, just because you have seizures doesn't mean that you're not eligible to receive treatment for perimenopause and menopause.
Okay. You are a fountain of wisdom and great information and guidance. I'm going to ask two more questions. And then, actually, while I do so, I'm going to ask if our administrator can reshare the link for the survey. Perfect. And so, if everyone can just take a minute while we go through these last few questions to scan the QR code or look to the chat for the link and just respond to this survey, it would be greatly appreciated. Okay, second last question here, Rami. So, what can I do to address vaginal dryness while on letrozole for breast cancer?
Yeah, I have a lot of patients with breast cancer, and so there are many low dose estrogens that are safe for women with breast cancer. I do find a lot of the time the medical oncologist providing the main, chemotherapy and guidance. Some might be very concerned about starting estrogen, so I usually work in consultation with them as well. But there are other non-estrogen vaginal lubricants. And certainly in our follow-up newsletter, I'm very happy to list some of them. But it isn't only estrogen out there, but some of the lowest dose estrogens can be taken safely. But I always make sure that when I do that in a patient with breast cancer on letrozole, that I have a good conversation with the medical oncologist.
Okay. There were a few questions actually about uterine ablations. So, what is your opinion on uterine ablations during perimenopause?
I love uterine ablations. Uterine ablations are an amazing surgical option for women with heavy bleeding during perimenopause. It is a 90-second procedure. It saves women from major surgical intervention. You can go home the same day, usually back to work within a couple of days. So for the right person, after conversation, I know you've heard me say this a million times with a healthcare practitioner, it's an excellent option.
Okay, fantastic. We are just 5 minutes to go here. So I just want to take a quick minute and thank you, Rami, for all of this incredible information. I think you've been, really patiently answering many, many, many questions all over the place, right? So all these great questions that we have from all of our attendees. So thank you for all of the great guidance and advice. And I also want to thank everyone who attended tonight. Thank you for taking some time out of these, sort of last weeks of summer to join the call tonight. And lastly, and very importantly, want to thank OTIP really for your sponsorship of this session and for prioritizing women and women's health needs, as part of the benefits and health strategy that OTIP supports. So thank you to everyone. And just a reminder that the session tonight was being recorded. And so you can visit the OTIP June Health portal where you had registered for the session to see the recording and to see answers to any questions that we didn't get a chance to get to. As Rami shared, we will put together a newsletter with some of the common questions and answer anything that we didn't have a chance to get to tonight.
Yeah, great questions.
Yeah, so thank you, everyone. So that concludes our session tonight. And as I said, really appreciate your attendance and wishing you all very good health.
Have a good night, everybody.